Good evening, all. Uh, Today, I have decided to take a small class on complete heart block because yesterday I got a in the evening I got a call from Surya. Ki sir, look, there is this patient who has presented with breathlessness and is feeling giddy. So subsequent to that, I told him ki look, he sent me the ECG and then I told him ki look, this is the ECG of a complete heart block. So we are more interested in knowing what complete heart block exactly is. So in today's evening's discussion, what I will do is I will first tell you something about the conduction system of the heart. I'll not go into very details about what the physiology of the conduction system of heart is. Uh, somewhat what is required just to give you a rough overview of what the conduction system of heart is, and subsequent to that I will start explaining you what different types of AV nodal bradyarrhythmias are. So we all know that sinoatrial node, which is located in the sulcus terminalis of the right atria, exactly where the superior vena cava drains into the right atria, there is a portion called sulcus terminalis. It is called the pacemaker of the heart because it has got its own atomicity. Now this myofibrillar cells are quite different from the other cells of the atria. And these cells that you see over here, these cells are protected by a layer of, or rather it is insulated by a layer of fibroblast epithelial cells and some more matrix, say extracellular matrix. This whole conduction system that you see, it is isolated and it is kept insulated from various currents of the heart by this extracellular matrix and this myofibrillar cells, so that there is no short circuit in between. So this sinoatrial node, it has got a atomicity which is around 60 to 100 per minute. During the young age, the atomicity of the heart is controlled by the parasympathetic tone. That is, the parasympathetic tone is high and the rate of the sinoatrial node is controlled by it. With what happens with aging is, with the gradual aging, because of the senescence, the parasympathetic nervous system, the effect of parasympathetic nervous system dies down, and at the 80 or the 90th decade, the sympathetic overdrive takes over. So it is during those times when SND, that is the sinus node dysfunction, sets in. From the sinus node, the impulses are conducted to the AV node. AV node is also called the gatekeeper of the heart. It protects the heart from the various other eddy currents that is being floated around, and of course it is insulated. So after having a generalized delay of some time, the impulses are conducted further down below to bundle of His. From bundle of His, it goes to the left ventricle of the heart, where we have got this left anterior fascicle, and then we have got this left posterior fascicle, and there is this right ventricle is innervated by the terminal Purkinje fiber of the right ventricle. So when we talk about this conduction system has to be considered a isolated insulated vase. Now the heart was built in such a way that if the first generator of the heart phase, the first atomicity of the heart phase by the sinoatrial node, there are various other places where the atomicity is higher than the surrounding tissues, so it takes over. So in case the SA node fails, the AV node can take over. If the AV node fails, then there can be suprahisian rhythms which can take over, right? So we also must know that the sinoatrial node in around 55% of the cases is supplied by the right coronary artery. Right coronary artery also supplies the AV node via the AV nodal branch. AV nodal branch. This that you see, the bundle of His, is supplied by the perforating septal branches, interventricular septal, so septal branches of the LAD. And in 40% of the cases, the sinoatrial node is supplied by the left circumflex artery. So when the sinoatrial node is supplied by the RCA, we call it the right dominant circulation. When it is supplied by the LCX, it is called the left dominant circulation. With this basic overview, we go on to the understanding the heart blocks. So are all the heart blocks senile and degenerative in conditions, or the AV nodal disease? No. So what can be the other causes which can be prevented or should have been analyzed before we go in for the management of the AV nodal diseases? So first is a Leaves disease, which is the senile degeneration, Lenny-Grace disease, which occurs as a younger age, same senile degeneration, sometimes the calcification of the aortic annulus, and sometimes very lessly the mitral annulus. It also can encompass the AV node and leads to AV nodal block. Iatrogenic procedure, the procedure when you are conducting on the heart, like you do a valve surgery, you are doing a TAVR, you are doing a transaortic valvular replacement, you are doing radio frequency ablation. This all can cause iatrogenic AV nodal display. Then are of course negatively chronotropic medications like beta blocker, verapamil, diltiazem, digoxin. This also can cause drug-induced AV dysfunctions. Then subsequently toxins, acute myocardial infarction. Oh yes, that I have told you. The this pacemakers like the RCA, AV node, they are supplied by the RCA, and then again a massive anterior wall MI also can lead to complete heart blocks. Infectious diseases like Lyme's carditis, bacterial endocarditis with perivalvular abscesses, Chagas disease, toxoplasmosis, infiltrative heart diseases caused by sarcoidosis, amyloidosis, hemochromatosis, rheumatological illnesses like SLE and systemic sclerosis. Then of course there are other congenital causes of heart block like maternal lupus, and congenital heart diseases like ASD, VSD, endocrine disorders like thyroid disorders. Don't forget about the thyroid disorders. Heart and thyroid, they are linked to each other. So thyroid disorders as well as hypoaldosteronism can cause AV nodal disorder, and then subsequently, not to add, the congenital myotonic dystrophies. So with all this in mind, of course, dyslipidolitemias, hyperkalemia, though AV node is quite insulated and it does not react to extrinsic changes of potassium, but massive changes in the serum potassium within a very short span of time can lead to AV nodal display and complete heart blocks. So first is, what is this AV blocks are divided into type 1, type 2, type 3. So what is a type 1 block? A simple type 1 block is when you see this ECG, there is this P wave, and with the P wave there is a long pause. So it is a misnomer. AV, the first AV block is a misnomer term. There is no block itself. It is only that the conduction of the impulses slows down. So in this, when the PR interval increases greater than 200 milliseconds, it will be called as the first degree AV block. You see this? So it is greater than 5 small squares. So greater than 5 small square will be first degree AV block. Now we come to what is type 2 AV block, or type 2 AV block is classified into Mobitz type 1 and Mobitz type 2. Very easy to remember. So what is the first type? Mobitz type 1 block. Now let's look at the rhythm rate. Over here, I wish I could have a better ECG. Over here, if you see, this is a type 1 Mobitz block. So what happens in a type 1 Mobitz block is, you see here, this PR interval keeps on increasing, and then what happens? This P is not getting conducted. So when this happens, there is a gradual increase in the PR interval. Finally, there is a P which is not conducted, signifies Mobit's type 1 block. Okay, you see this. There is a PR which gradually increases, it gradually increases, it gradually increases, and then there is a drop. This P is not getting conducted. So this is Mobit's type 1. So what is a Mobit's type 2 block? Mobit's type 2 block is the PR interval remains the same. The PR interval remains the same. But somehow this P does not get conducted and it signifies a intermittent heart block. So the PR interval remains the same, but one of the P's does not get conducted. One of the P's does not get conducted. So hence this is called as a Mobit's type 2 block. Now coming back to our index case, which our dear friend Surya had seen yesterday night. So this 86-year-old female, already known medical comorbidities. She was a case of chronic stable angina and had undergone a PCI to left anterior descending artery and had a normal EF. And she was also a case of primary hypertension. She presented with breathlessness, NYHA class 3 of 2 days duration and giddiness with graying out in the front of eyes. She was having pre-syncopal attacks. Clinically, pulse was 50 per minute, respiratory rate was 22, SpO2 was 98% at room air and BP was recorded to be 190 by 110. In CVS examination, S1 was variable. And then I get this ECG from the emergency department. So, firstly, are the P's seen over here? Yes, the P is seen over here. And once you see these P's, what you realize is, in a normal ECG, every P is supposed to be followed by a QRS complex. That is how you get a normal sinus rhythm. But over here, if you see, the P's are totally in a disjunction fashion. It has got no periodicity, or it does not maintain a periodicity or a rhythm with the following QRS complex. It has got no relationship. There is a complete AV dissociation, atrioventricular dissociation. Atria, it is going in some other way. The ventricle, it is going in some other way. So what's happening over here? The thing that is happening is, in the atria, the sinoatrial node has taken over and it is beating on its own. And over here, this is likely a junctional rhythm. The AV junction has taken over as the pacemaker of the rest of the ventricles. So over here, the AV junction has started pacing the heart, and that is how you get a narrow QRS complex ventricular rhythm. If some sub-Hessian pacemaker would have taken over, I would have considered the rhythm very unstable and it would have led to a very large QRS complex, very large QRS complex. The pattern must have looked like this. So, what is the treatment? If you are located in a PSC and you cannot, and the patient is symptomatic, he had a syncope, he is going into a stroke Adams attack, the treatment is give them atropine, IV atropine, monitor the heart rate. If it is still less, you can put the patient on isoprenaline infusion. A lot of things have been tried. The things that have been tried are allopant, isoprenaline, doxophilin. To tell you the truth, nothing works. So the best thing that is to have is a transcutaneous pacing. The transcutaneous pacing, they just look like defibrillators. The basic, if you go and you see the Medtronic ones, they give you these pads. So when you get these pads, the first thing is you have to place it anteriorly over the chest, and the posteriorly you have to place it in between the spine and the scapula. So once you have placed, and you just mention the rhythm, but this is just going to buy you time of around 30 to 45 minutes. By 30 to 45 minutes, he has to be in a capable center who can transvenously pace the patient. So we go to what is transvenous pacing. So transvenous pacing is what we do is we put in a lead through the subclavian vein or in an emergency through the femoral vein, and we reach the right ventricle, and we give impulses as desirable to keep the patient alive, and then you go in for a permanent pacemaker implantation. So permanent pacemaker implantation is once again a you can go in for a single lead pacemaker or a single chamber pacemaker where you place it and in the right ventricle, and you decide to pace it. So what happens is, it is a very mechanical kind of a device. It does not understand the need of the body. In a long run, when you have already put in, you have stabilized the patient, you have already put in a permanent pacemaker. So what happens is, it will not understand the demand of the body, whether you are asleep, whether a person is running, whether a person is eating. It will pace on its own without understanding the demand of the body. And it can even like, how does a heart function? First, there is a diastolic filling of the left ventricle, and then there is atrial kick, and then finally the ventricle closes, and then it relaxes. So there is, in case of a single lead pacemaker, what will happen? There will be a dissynchronization between the atrial kick and the ventricular contraction. So this will lead to something which is called as there is a dysynchronization going on, because this is pumping on its own, the atria started pumping on its own, and the ventricle has started pumping because of the pacemaker. So this is called, this discomfort we call it as post pacemaker syndrome. I will not go into details of that. The second thing that you can do is, you can program the pacemaker in such a way that there will be one lead which will be sensing what is the demand of the atria, that is how to sense what is the atrial rate, and then subsequently pace the heart by giving a pacing beat. So every atria will be sensed, there will be a sensing spike, and then there will be a pacing spike, and there will be a ventricular this thing. So the ECG will look something like this. There will be a sensing spike, and there will be a pacing spike, and then the ECG will look like this. Whereas in this case, what will happen is, there will be P waves throughoutly distributed, and then there can be a pacing spike over here, and then will be ventricular spike. This will forget about. Then there can be a ventricular spike over here, then here, irrespective of wherever the P wave lies. It will forget about the P wave. So what are the latest advances in pacemaking? So you see over here, what we see over here is a dual chamber pacemaker. This is, we call it dual chamber pacemaker. This is the atrial lead which is lying over here in the right atria, which senses, and then there is a RV lead where it is pacing the heart. So what is this structure that you see over here? This is a miracle of modern medicine. This is Micra. This device is known as the Micra. This is a very, very, very small pacemaker put into the right ventricle, where it is sensing also and pacing also. And this pacing spikes which Micra gives, it can be more physiological by just making it pace near the bundle of hairs. So what will happen? The contraction of the heart will be in a more physiological manner. Okay. So I have come to the end of the discussion for the complete heart block. Next class, I will be discussing another emergency. I'll just show you this ECG, and we'll have this class very soon, this week itself. And just have a look at the ECG, and do drop down your comments so that I can, please tell me what classes you really require, so that I can make those classes and send it across to you. Thank you so much for listening.